Good afternoon from Athens, Professor Goudoever. Thank you very much for accepting our invitation to our Excellence in Paediatrics Expert Online interview.
Thank you.
Your colleagues have a range of questions for you today on neonatology and gastroenterology, your specialist interest subjects.
Yes, that's perfectly fine with me. I've been doing that kind of work for a long time now, so
that's great.
Yeah.
Okay. So the first one then, what's the best breast milk substitute for a newborn?
Well, first of all, I like to stress that the best thing to do is to have for at least 4 to 6 months own mother's milk. That's I think from WHO, from the ASPCON Committee on Nutrition. Basically, all important committees around the world advise 4 to 6 months breastfeeding. However, sometimes that's not possible, and then there are many infant formulas around who are that are very good substitutes. Preferably a liquid one, because especially in places where the infection rate is high and the sanitary conditions are not that good, liquid formulas are best, but of course they are more expensive. The second best is powdered infant formula.
Okay, thank you. Next question. How can we feed very low birth weight newborns in neonatal intensive care when there is no parental nutrition?
Basically, the first answer to that is that one should try to convince hospital directors that parental nutrition is life-saving and has a huge benefit on the long term. So it's more important to have a pharmacy in the hospital that provides parental nutrition than, for instance, buying a new ventilator system for neonatology. But if it's not possible to have parental nutrition in your unit, then the best option is to start as early as possible, again with own mother's milk. Start on the first day of life, advance with 20 to 30 mL per kilo per day each day, and continue until the baby has an intake of around 150 to 200 mL per kilo per day.
Okay, thank you. What is your opinion about breastfeeding of newborns by mothers with epilepsy who are taking anti-epileptic drugs?
Well, that's an important question, and there are some drugs that are transferred to breast milk, and they can influence mostly vitamin K metabolism. Those drugs are phenobarbital and phenytoin. They act basically also like rifampicin and isoniazid, and those are so for phenobarbital and phenytoin, one should not give breast milk to the baby if the mother take that drug.
All right. Now, next question. Do all preterm neonates or term neonates in the early gestational weeks of 37 to 38, when given an ultrasound scan, have signs of gastroesophageal reflux as a sign of physiological hypotonia and developmental immaturity? Your colleague says that when they performed ultrasound by mistake on neonates without signs of gastroesophageal reflux, we got this diagnosis and now they have a dilemma. Do they need special formula?
That's an intriguing
huge
question. Because this gastroesophageal reflux found by accident, so to say, then one can question whether one needs to treat that. So basically my question would be no. My answer would be no. Motility develops over time in term and preterm infants. The younger you are, the more reflux you have. So this is physiologically, and especially when the baby has no clinical symptoms, there's no need for a specific formula.
Okay, thank you. is it ethically acceptable to test new drugs, usually in the third phase superiority trials, among unprivileged neonates and infants from very poor rural slum communities where low birth weight, anemia, protein, calorie malnutrition are endemic?
That's also an important question, and I think yes. The answer is yes, but there are some rules to it. First of all, one should have to do those kind of tests. One should have, of course, approval from ethical committees or institutional review boards, etc., etc. Then secondly, one definitely needs informed and even written informed consent from the parents. So those are two conditions that are obligatory. If these conditions are met, then my answer would be yes, because the infants usually in trials are better off than infants who are not in trials. And then especially in those poorly developed regions in specific countries could benefit from a certain set of controls that would enable researchers to identify some problems that those infants might have and refer them to specific treatments.
Thank you. Lastly, what are the modern views on the requirements of newborns regarding proteins, fats, carbohydrates, kilocalories, and water? And first, we'll deal with that one. Yeah.
That's also a question that asks for a huge answer. So best is actually to refer to a paper that we wrote just a year ago, which is published in Journal of Pediatric Gastroenterology, Hepatology and Nutrition. It's published in the January issue of 2010, where we have a joint statement of many authors, world known, on nutrition for preterm babies, and there the specific requirements for infants up to 1,800 grams are given.
Okay. After the first 28 days of life, how do these requirements change?
Well, basically, they don't change that much. Also not, because that's going to be the second one, if the baby is seriously ill or has syndromes or multiple dysfunctions. Infants, we don't know the individual requirements at specific disease states. That's just that we haven't the data yet. But on average, one can state that infants who are seriously ill have about, or at least, the similar requirements than infants who are at a good health condition. So basically, if one can meet the requirements set in that specific paper, they're much better off than they normally are at the moment.
Okay, and then lastly, the last part of this question, if the newborn is seriously ill or has a syndrome of multiple dysfunctions, does this situation change?
Well, basically not, because the major requirement for preterm neonates is with regard to their growth. And that should not change. And actually, the aim of a neonatologist should be that the growth is sustained even during periods of illness.
Okay, thank you very much, Professor. So I'd like to thank you then for giving us this very interesting interview. Thanks to all our colleagues for sending in the questions, and have a nice weekend.
Thank you very much. It was a pleasure.
Thank you very much indeed. Bye.
Bye-bye.